So the question here was cardiac CT perfusion stress or not to stress. And let me tell you my personal point of view regarding what to do on intermediate coronary artery stenosis. So I will tell you what I think or what I do or what I think we should be doing. But again, it's a personal thing that we can definitely discuss later on. So I would say that there are two main studies, or my favorite two main studies in cardiac CT are this, the Scott-Hart trial and the discharge trial. The Scott-Hart is a very well-known study. The first results, 5 years results, were published 2018, and this has been published this year, January. And this study says that you can manage your patient with coronary CT angiography. So don't do anything else, just do CCD guided management. And that's why NICE guidelines have adopted this from the very beginning, 2016, and still. So what happens is very interesting, because what you see here is that the outcome of the patient is similar or better for CCTA, as you can see. The P is almost 0 point, but that's fine. But the other interesting thing is that when you look at the MACEs, that what happened is that with CCTA, you are detecting coronary artery disease that you cannot pick up with the regular conventional clinical protocols. With CCT, you see the atherosclerosis and you treat the atherosclerosis. And that's why you have better outcome in the end. This is one study. The other study that I like a lot is the discharge trial. In this one, instead of comparing CCT angiography with the conventional care, like stress test, treadmill test, etc., they compare it directly with invasive coronary angiography. And here they say that it doesn't matter what you do first line, CCTA or invasive coronary angiography, the results at the end will be very similar. So here you see the risk of masses, so MACEs, major adverse cardiovascular events, was similar in the CT group and the coronary CT, and in the invasive coronary angiography group. So we have a very, very powerful tool that I showed you earlier. We use it to rule out disease. So if you think that someone has possibly coronary disease and you want to say yes or maybe no disease, do a CT. And that's why in the guidelines, it's very well established that you should be using CT in patients who have very low risk or moderate risk of having disease. If you suspect that he will definitely have disease, don't do. High risk individuals, maybe you shouldn't be doing that. And very low risk, you don't need to give extra radiation. Maybe with a calcium score, you can reclassify the patient. This is how we have it now. Very likely, I envision that in the coming years, this will change, the paradigm will change, because we will have a CT, which is a photon counting CT. And with this CT, we will be very likely doing patients with high risk. And we will be doing very low risk patients too, because we will have the ability to characterize easily the plaques. This is photon counting CT, 63-year-old male, former smoker, dyslipidemia, family history of coronary disease, shortness of breath. See the anatomical detail you can get. See there is no blooming, and see how well you can depict even in difficult areas, the stenosis, and see how it very similar images conventional compared to conventional coronary angiography. I'm saying that high-risk individuals with stents, see the sharpness, the anatomical detail. See how you can even see how the strut went into the LAD. It's only 1 millimeter, and you see it with photon counting. So this is present, will be the next coming feature with the coming CTs. But now what we have is a study, a CT, that has a sensitivity of 90%, very good to depict stenosis, specificity of 0.4% patient-based, meaning that I'm very good at detecting, not very good at defining what do I have, what's the degree of stenosis. So this happens because Costas has shown us earlier very, very nicely that we have many limitations with CT, particularly based on the patient's calcification, stents, metallic implants, arrhythmias, many artifacts that are very nicely shown earlier. They are a very important limitation for CCT angiography. And of course, we do also have contraindications for the test itself, like iodine, pregnancy, etc. So very frequently, our problem will be one, we will overestimate the degree of stenosis, like in here, that I said that the patient had 50 to 69% stenosis. They did an FFR and it's negative, 0.08. Or in this case, that it has a lot of calcium and the patient has chest pain. I did a Calrat's N in this case. I tried to avoid that, but I couldn't say anything here. And actually, the patient has stenosis there. So many, many limitations. So what do we do in our regular practice? 59-year-old male, smoker, hypertension, hypercholesterolemia, type 2 diabetes, atypical chest pain, undergoes an exercise stress test, clinically negative, so it's a questionable stress test that we don't know exactly what's going on. They order a cardiac CT, and this is what we have. So here, again, it looks like everything is fine, but suddenly I have plaque here, what's going on in the proximal LIT. The circumflex looks nice. What can we do? Usually what we do is we send the patient for a stress test. So we order another test, and then we perform this stress and rest, and we see that there is no perfusion deficit. So this patient is fine. He doesn't need anything. If he needed something, he would go to a cath. But the big issue with the cath is that when you do a cath, you can detect stenosis easily, but some of them are not functionally significant, and others, even being not so severe stenosis, are clinically significant. And you cannot depict that with invasive coronary angiography. So a patient has atypical chest pain, fine. You take him to the cath lab, you do a cath, you see stenosis, and you suspect the pain comes because of this stenosis, and suddenly you put a stent, and then he comes 2 years later, and the patient has still pain, he has a stent, so he is a diseased patient, and you didn't relieve his symptoms, and he's equal, but with a stent, antiaggregation, and all these matters. So what they do in the cath is, let's try to characterize better this, and I will do an FFR. And the FFR is very simple in the terms of they put the stenosis, they measure the pressure distal to the stenosis, proximal to the stenosis. And if there is a pressure drop 0.8 or less, they consider that this is clinically significant. So this means that if they have a question or the clinical symptoms, etc., don't match, they see stenosis, they do an FFR. And now this is the standard of reference. So they will treat the patient based on FFR, and if the FFR drops, they will do a PCI, they will put a stent. Theoretically, if the FFR is more than 0.8, they will not or they shouldn't be treating the patient. That's the idea. So this is the scenario that we have. We have a test, coronary CT angiography, which is very good to detect the stenosis. Sometimes we have limitations, we will order a stress test. That's a regular practice. If he goes to the cath, they do a cath. From the hemodynamic perspective, they do a cath. And if it's questionable results, they will do an FFR and decide whether to stent or not. So having all this picture, what can we do with CT? And that's the question, stress or not to stress? Do you want to be like this? Do you want to be accurate? 2 and 3. This is the test we have, a CT. Is it accurate? Let's see. This is not AI. This is not the future that we were talking about earlier. This is what guidelines are saying 2021. So 4 years ago, They will telling us you should be doing, maybe appropriate, to perform an FFR and CT myocardial perfusion in those stenosis that are questionable, like the 50 to 90%, 30 to 90%, depending on what you read. That's the guidelines. So you should be doing something more than rather than doing another test or deferring the diagnosis or sending the patient to the cath without knowledge. You should try to push your CT to try to be accurate. And you can do it in two ways. They are suggesting, one, do a perfusion, as I was doing with MRI in the case, do it with CT. And the other one is, have you seen what they do in the cath lab? Yeah. Okay, now there is a computer that can add info and do something similar and try to mimic the FFR that the person in the cath lab will obtain. So you understand the two scenarios, the perfusion that we do and the FFR that the cath lab people do. Let's see if we can manage that with CT. If you go to the guideline 2021, the American guidelines already say a stress testing of FFR CT, and the new guidelines 24, they say that you could do FFR CT. So there is already in the guidelines, the actual guidelines, that they say that you should go beyond coronary CT assessment alone with CT. And how we do it? 52-year-old male, hypertension, hypercholesteremia, he's a cyclist. Central chest discomfort during physical exercise for the past 2 months. I saw this. I said, this is less than 50%, but the patient has symptoms. Let's do a perfusion. Perfusion deficit. If I compare, there is a perfusion deficit. So this test anatomically is negative, functionally is positive. So see how you can answer the question of the patient directly on the table, directly. And you can do it, we've seen it earlier, in two different ways. And we have to decide how to do it. We can do first stress and then rest, or we can do rest and then stress. We have to decide. Personally, as I see or as I believe what CT is and what is CT for, I would go for a rest stress protocol. And why is that? Because don't forget that CT is to rule out coronary disease. So the ideal scenario is that you do a CT, you don't see anything, you send the patient home. And if you see something, then you stress the patient. In other ways, you can say this has tons of calcium. Very unlikely I will see something in the coronary angiogram. I will go directly and do a stress perfusion first because I like to have a clean myocardium. That's the other approach. Personally, I believe in this one. And right now, I prefer to leave those patients for a cardiac MRI. This is how I do it in my regular practice. So first, do a study. Look at the study on the table. When the patient is on the table in the CT scanner, the console, you see it, say, questionable disease here and here, I will do a perfusion. You talk to the patient and say, I agree. Okay. Here depends on the availability. In my hospital, it's quite available, everything. But imagine that you have a patient and say, I will call, we can do it right now, or I can schedule a perfusion scan for when? In Spain, there could be a waiting list of 3 months for some tests. And he says, okay, let's do it now. But again, this approach, I like it. The other approach is, how would I do the perfusion? And I can do it in two ways. One that Costas likes is, let's do a static perfusion. I will put a vasodilator, stress, and acquire the image. The other one, dynamic approach, mimicking what I do in MRI. This one. And this will depend on the scanner capability. Depending on the CT system that you have, you can go for this or this. Or even you can go for this, which is a spectral imaging, which is like the good thing of doing static imaging is try to quantify the amount of iodine. Here you can see a perfusion deficit, barely eyeballing, but measuring, you can see that there is a perfusion deficit, this mid-distal LAD stenosis. So you can do one or the other. You have to choose. There are different ways to choose, but one interesting that I like is that with dynamic, you quantify. Again, I don't have a threshold value that I can tell you. If you do dynamic and it's less than 80, it's ischemia for sure. No, we've learned that it's not like that. We will see it in the cases later on. We will discuss this when we do the hands-on thing. Again, the good value of dynamic perfusion is that you quantify. So depending on what you have to choose. The advantage, this slide was previously shown, the advantage of a static perfusion is that you can even in one single acquisition assess the coronary vasculature theoretically and the perfusion. That's the theory. A systolic acquisition, for example, which is more robust for high heart rates, you could potentially do that. But you have one drawback, is that the number of artifacts that you will find are much higher than doing dynamic perfusion. The advantage of doing dynamic perfusion is that you quantify the MBF, the myocardial blood flow, so you get a number. With a static perfusion, you see the hypodensity of the subendocardium, and you have to define if it's an artifact, a blooming effect, or something. With dynamic, you quantify the amount, so that's great. But has a significant drawback. You have to inject more contrast, 50 milliliters usually, and you give more radiation, usually around 4 to 5 millisievert more, of 3.5 to 5 millisievert. It's not a big deal, but it is. It is amount of contrast and amount of radiation. That's from the technical perspective. But if you don't have something that's dynamic, or you don't have something that's static, don't worry. Sensitivity and specificity are very similar. So any modality that you choose for cardiac perfusion, you should have the same results or very similar. It's true that quantitative is a little bit higher sensitivity. So first pass imaging is slightly more sensitive, but the specificity, they are both the same. So it doesn't matter which one you choose. When you do cardiac perfusion, any of them that you would choose, it would be correct. And in my practice, what does cardiac perfusion add to my practice? CCTA in blue, stress CTP, just perfusion, red, CCTA plus CTP in orange. See how when you add coronary angiography plus perfusion, you improve the diagnostic performance of the test. So this to me is very important, because now if I have a question regarding is this a significant stenosis, I will do a perfusion test, because I know that I will be more accurate than just doing coronary CT angiography. So in my environment, stress, yes. Not to stress, FFRCT. Here I'm not giving any drug. I've just used the images that I got from the coronary CT angiography and put it in a sophisticated computer module that will analyze the anatomy, the physiology, and the fluid dynamics. So it's computer-based analysis, computer-based. Principles that have to be fulfilled because of the computer program, how it's made. That could be, we could discuss these principles if they are met in all patients or not, but this is what the program is built in, the methods. CFD, this method, there are other machine learning methods, etc. But the bottom line is that what you do is you calculate the pressure gradients with a computer and define a number. And this number is 0.82, so very similar to FFR. One software, for example, here, where you can see an LID stenosis and how the FFR drops. Different softwares out there. What's the main advantage of using FFRCT? We were saying that with CCTA, you have high sensitivity and low specificity. FFRCT, what lowers the sensitivity but increases the specificity quite a lot. We were saying 40% earlier, now we're going to 54, 86, 63, 54, 82. So increases the specificity. So in my practice, when I use FFRCT, I see something similar to what I've seen with perfusion CT. In here, this article is in press now. In here, we've got CCTA in blue, very sensitive, but the specificity is a bit low. FFRCT alone, so I have no idea, I just put it in the machine and I get the result and analyze this in numbers, in green. Low sensitivity, higher specificity compared to CCTA. But if I combine both, see again how the area under the curve improves significantly. So very similar to what has happened to me with myocardial perfusion happens to me with FFRCT. Publications say that you optimize the resource, the use of resources, like you send less patients to the cath. But the interesting thing here too is that as you are using the anatomy, you can plan how you're going to revascularize the individual. You can potentially do that. However, this is not the golden thing. FFRCT showed higher diagnostic performance than the rest of the tests, provided that CT images were evaluable. It doesn't even say good quality, it means evaluable. So it needs more than good quality. FFRCT needs excellent quality images, and there are many, many limitations for the FFRCT calculation. And the patients with a lot of calcium, patients with stents, patients with pacemakers, patients with anything that can cause potential artifact in the coronary lumen are not good candidates for FFRCT. There is another limitation of FFRCT that has to be known, that usually you pay per case that you analyze. More things. Another limitation. FFRCT is very good in saying no disease, more than 0.8, or saying definitely he has disease, less than 70%. See the correlation. But when you correlate, 46% is the correlation that has with the conventional FFR. So not all the times that you measure 0.79 means that the patient has 0.79 with the computer and with the invasive coronary angiography. That's why now we don't think about an absolute number, we think about the patient itself. So if you've got an FFRCT of 0.75, usually we recommend a cath. If the patient has more than 0.8, we recommend clinical follow-up. And if the patient has a gray area between 0.76 and 0.8, we recommend a follow-up. And after 3 months, with medical therapy, if he's fine, that's fine. If he has worsened or it's equal, then we recommend a cath. This is usually how we do it. So my question now, and everybody's asking the same thing, is what to do if I can do in the same individual this. What do you recommend? So what I say is that there's one paper saying that it adds everything. In my personal experience, it doesn't add. So what I would say is that this is in blue. You see here everything. What happens is that when you do CT alone, you detect a lot, but you are not very specific. When you do perfusion or FFRCT alone, you increase specificity, you lose sensitivity. When you add any of this to CCTA, it improves performance. But when you add the three of them, so I do CCTA plus FFRCT plus perfusion, it doesn't add. So the area under the curve, the accuracy doesn't add too much. So my belief here is that we have to decide what kind of patients we have, one, and what kind of availability I have. Depending on the patient, if the patient will be a good candidate for FFRCT, maybe we could perform that provided that we can pay the amount of money that it costs every case. But if I have a good CT that allows doing perfusion CT, what I would encourage you is to do perfusion CT, because you can solve right away the problem of the patient. If you have a patient with coronary stents, if you have a patient with coronary calcium, I will go directly for a perfusion CT. So in conclusion, and let me conclude, I would say that the clinical benefit of revascularizing a patient is limited to the lesions causing ischemia. So we have to detect this, not only the stenosis. We have to define that the patient has ischemia. CT allows reliable exclusion. You can exclude easily, but it's very low specificity. You shouldn't be trying to. You should go farther, be more specific, and for that you should use stress perfusion, or you should use FFRCT. I think that both have demonstrated the hemodynamic significance of stenosis and expands the clinical utility of CT. In the coming years, we will be talking about photon counting CT. This improves significantly the spatial resolution, so the anatomical detail. And very likely, it will also improve the calculation of FFRCT, and very likely, with the spectral capabilities, it will allow to perform a good perfusion CT, but we are not there yet because this is still under research. So with this, I thank you very much for your attention.